Greetings to my fellow emergency medicine personnel. This is David Didlake with EMS 12 Lead, and I'm going to present a case review regarding a missed opportunity for early cath lab activation. So let's just jump right into this. Here is the time 0 12 lead ECG for a 42-year-old female who called 911 for new onset chest discomfort. Crews found her otherwise stable. There was no significant vomiting or diaphoresis, but she was quite uncomfortable, rating centralized chest discomfort at a 5 out of 10, nagging and unremitting. No significant personal history, no significant family history. Now you can clearly see that there are some suboptimal characteristics at first glance here. First of all, V5 is completely missing. And V1 and V2 are placed a little too high on the chest because you can see that both show inverted P waves and they share a similar axis with AVR. And whenever those are in combination, it's a good possibility that these two leads are placed too high on the chest. And in this case, they're essentially diagnostically useless. So we have some broad-based ST segment depression here. Should we be concerned about this? Well, of course, any ST segment depression merits a further scrutinized investigation. And something we should ask ourselves is the ST depression truly broad-based? That is spread out globally across the ECG, and is it maximal in leads 2 and V5 that would be consistent with subendocardial ischemia? And despite the fact that V5 is missing, it looks as though V3 shows maximal ST depression. And then over here in the frontal plane, it looks as though lead 3 is showing maximal ST segment depression. So that should cause us to take pause and say this is most likely not generic subendocardial ischemia of acute supply-demand mismatch, but rather this is focal to a primary injury. Now, do we see any dramatic ST segment elevation? No, we don't, but there is good examples here of T-wave hyperacuity in leads 1 and AVL. These T-waves are large, they're robust, there's a significant area under the curve, they're bulky. The proportionality is such that the T-wave completely outsizes the respective QRS that it's paired with. So this ECG was actually captured by the first arriving engine company, and the ambulance was coming from the other side of town, and by the time they arrive, they capture their own, which shows this. Now you can see that the T waves in leads 1 and AVL have swollen even to a greater degree. The ST segments of these respective leads are not elevated by any gross standard definition, but the T waves have enlarged significantly. There's increased area under the curve. The proportionality has exceeded greatly in terms of their size with the respective QRS that they're paired with. Now let's go back to this idea of broad ST segment depression. Does it still fit a specific focal example, or is this consistent with generic subendocardial ischemia? Well, it seems to me that here in V3 we have a continued display of not only ST segment depression but dramatic ST segment sloping. You don't really appreciate that here in V5. And over here in lead 2, if you're going by technicality off of the PQ segment, then the ST segment is actually kind of baseline with it, whereas below it in leads AVF and 3 you have significant downward sloping ST segment depression. So this ECG is pathognomonic for acute myocardial infarction. No STEMI was activated pre-hospital, and in fact, the emergency physician who received this patient did not find the ECG characteristics concerning at all, and on top of that, the on-call cardiologist did not find this particular series of ECGs concerning. So the Swiss cheese effect, so to speak, of stopgap at some point, somebody should have recognized this, it just went completely undetected. So the plan was to have this patient medically managed, admitted to the telemetry floor, but as it turns out, her pain could not be mitigated effectively in the emergency department, and that pain continued to grow despite maximal pharmacological therapy. So the cardiologist decided to take the patient to the cath lab. Here's a view of the RCA. There's really nothing too dramatic. There's some stenosis down here. It looks like the offshoot of the posterior descending artery, but otherwise good laminar flow along here on the RCA branch. But this right here was the problem. This is a good view of the left main LAD, and what I'm pointing out right here is actually a coronary artery dissection of the obtuse marginal. So this patient actually required a surgical consult to have this repaired. So the ECG does not know why it's having an acute infarction. It's just the cells are going to respond regardless of the underlying mechanism for an acute occlusion of the principal vessel. Why do hyperacute T waves matter? Well, here is a snapshot of the Sklerovsky-Birnbaum gradation. Now, said gradation is it's the time-sensitive prelude to Q wave formation, which is irreversible transmural scar. And in the original publication by Sklerovsky and Birnbaum, they discovered that with each grading escalation, there is less salvageable myocardium and higher likelihood of heart failure at the point of hospital discharge. This is crucial to not only us in the pre-hospital environment, but it's also crucial to our emergency medicine colleagues and our cardiovascular colleagues, because identification of grade 1 ischemia here, as demonstrated by hyperacute T waves, this addresses the culprit lesion or the culprit incident at the earliest opportunity with excellent downstream prognosis for the patient. So essentially, this is the difference between leaving the hospital with significant left ventricular dysfunction and sojourning a new path of life in heart failure versus being discharged with full myocardial function intact. I'm going to leave a link in the actual EMS 12 lead website for you to review hyperacute T waves, because in that particular link there's a great assortment of different examples of how hyperacute T waves correct or manifest themselves. So go forth and do good work, and we'll see you on the next time.